which, the elephant in the room, if we're going to start talking about transparency and drug transparency, is a conversation for another day. But you've seen the executive order, the Trump executive order on transparency.
Yeah. So this is an example of like what I was talking about. Trump did something last week during the impeachment hearings that I didn't approve of. And then I see the HHS secretary talking about his executive order, and I'm like, good for you, Trump.
Sure.
Good for you.
Sure.
I agree with you, man. That's fantastic.
I know.
We just talked about the need for transparency. And
he's a lot of things. Dumb isn't one of them.
Right.
He's not dumb.
Yes. He's trying to create a market.
He's as street smart as anybody.
Yeah.
But he's also a moron. And I wouldn't want to be married to him.
Yeah.
That's another conversation. There was something that I had heard when the Billy Bush stuff did come out that I could get this wrong, but I want to say Mike Pence refers to his wife as mama. And so it came out, and they were like, people were freaking out when they had heard about the Billy Bush thing and before the election. And he was like, that doesn't sound like me. That doesn't sound like me. And then somebody eventually came in with a recording. He goes, well, that's me. And he goes, oh man, this isn't good. Mama's not going to be happy.
Mike Pence's wife.
Mama's not going to be happy with this.
Mama's not going to like
Mama's
that.
not going to like this.
I bet he's right, too.
I bet he's right. I guarantee he's right. Mama didn't like that.
Mama's got to explain to everyone at church.
Mama's got a lot of explaining to do. You just made things difficult for Mama and Mike Pence.
Yeah. Yeah, I think about Mike Pence often.
Well, there's so much stuff. Of course, it was just released, and so it's supposed to go into effect, the beginning of 2020?
Sometime.
I mean, that's not a lot of time, right? If I got the timing right. Now, there's already been lawsuits coming out about this because the major hospitals. Now, I think it's an important thing to do, but you got to understand it's like nothing's going to change immediately. But
we're talking about transparency on what the negotiated rates are between insurance carriers and hospitals.
Correct. And what the hospitals charge for, I think it's 300-ish kind of services. They're trying to create transparency. So if it's 300, then there's like a certain number of other services that a person might have.
So that you have price tied to outcomes.
Well, no, see, that's one of the arguments against this is that not a lot of this, really none of it is tied to outcomes. But they're talking about releasing the secured type of claims data, de-identified data, basically would probably be on like all Medicare. Well, all the Medicare stuff is already out there. One of our friends here, Quantros here in Greenville, South Carolina, they've already done that. They have, in my opinion, the best quality metrics and outcome metrics in the country already. And so I guess what they'll be talking about is maybe the other data from, I don't know, other health plan data. I'm not exactly sure because they have the Medicare data right now that's already released, de-identified through CMS.
So the goal is for the consumer to be able to go to the hospital and know what they're paying
Correct.
for a procedure.
And some people say, people don't care. Right. So, I had a shoulder surgery in 2016, I guess, 3 years ago.
Yeah.
Didn't seem like that long ago. After you go through a shoulder surgery, it seems like yesterday because it's painful.
Right.
But, would I have cared how much it was going to cost? No, I was going to hit my deductible anyway. So in that case, people go, it doesn't matter. It's employer-based. It doesn't matter. But that's only partially true because, well, first of all, like having quality data about the physician or the surgeon, the guy doing it, would have been really important because I've seen some of this quality data. You see certain surgeons that have terrible outcomes, and they would be able to go, well, Trent, this just kind of, you're just prone for infection and just, sometimes this happens. No, this always happens with you based upon the data from Quantros, which we'll have them on sometime. Great guys, really, really amazing human beings and really amazing what they've done with their product as well. And so we've looked at a lot of that data to where some surgeons just suck. That's just all there is to it. You look at the data, they're just terrible. And some are incredible. And sometimes you have a facility like a hospital that, our local hospital, I've seen the metrics and I won't talk about that, but when you look at different hospitals and things like that, you're going to see lots of variations in infections and outcomes and all the rest. And so I think a big push of this is to try to make this very transparent, but they are right in that people are not going to go, well, I'm not going to use this orthopedic doctor for my shoulder because he costs $1,000 more. I have a deductible anyway. I'm going to hit my deductible. But who will look at it? Benefit brokers, employers, because they're not looking at one surgery. They're looking at 500 surgeries. They're looking at massive amounts of MRIs. Now, if you have an app on your phone and you can look to decide whether or not you're going to go here or you're going to go right there and save $300 on an MRI, yes, you will do that. So they're filing lawsuits already.
So who's filing the lawsuits? Who's the
hospitals.
Most? So the hospitals are the most perturbed at Trump's executive order.
I wouldn't go that far. I would say the hospitals and the insurance carriers. I mean, here's the bottom line: just backing up from all the drama,
because they're little private parties being broken up. Is it?
It's more complicated. The answer is yes, but it's more complicated than that. It's not. They do believe what they're doing is correct, and based upon the way things, I could even see their argument. I maybe even agree with them. But we all know things have to change, right? This is not our current structure. Is not going to last. You're either going to throw the whole thing out and go Medicare for all, or you're going to have to evolve a little bit. And major evolution, if you can't figure out in a consumer, when you can buy anything you want to on your phone, you can't understand how much a healthcare procedure is going to cost you, that's a problem. Now, I understand it's more complicated because you're looking at employer-based coverage, and that's the one point I didn't want to drop. Those are the people who are going to be looking at it. And so there's going to be tons of narrow networks, optimized networks to where they'll look and they'll go, all right, listen, these providers that are in the top third, we'll reimburse this. And these providers, these surgeons that are in the bottom third, we don't want you to do it from them at all. Why would we? Their outcomes are terrible. And so think about who's going to be pissed off about that. A doctor who's in that.
So it will change the network.
Well, it's going to change a lot of things. And so, it certainly is going to change from a person standpoint who works for a company and gets a medical card. It's certainly going to change because they might not care, but the people who's designing that plan that's on that card care significantly. And the employee benefit consultants certainly care because they're trying to get hired by the company so that they can design it so that it ultimately ends up on that card. Now, in terms of pricing too, insurance carriers, they don't want that public. And there's arguments on both sides. They would say, well, if a hospital, all the hospital's going to do is if this other hospital is higher than them, they're actually going to raise their price. Okay. Maybe in the short run. That's the thing that I was really wanting to try to get to, is that lots of things happen in the short run, but I think we pretty much know what happens in the long run. McDonald's doesn't raise the cost of their Big Mac. And then, Burger King looks at it and goes, man, you know what? We probably raised the Whopper too. And they don't just continue to do that. Mm-hmm. That doesn't work in our society because there's always somebody else that comes back in and goes, I'll offer you Wendy's will go, I'll offer you a double cheeseburger for right here. And then it always ends up coming right back down.
So if you're creating a market there in healthcare that doesn't currently exist, ultimately it should lower healthcare costs. And wouldn't that then in turn lower premiums?
Of course.
And so that is why another. Now,
as I talk about it, though, you could have a position to where you have two hospitals in a market that collude with one another. That's also a bad idea. Pretty sure you can go to jail for that one. But it's a complicated thing. And it's even more complicated because we're so tied emotionally to hospitals. That's where my baby girl was born. I love those people. That's where this doctor took care of me. He saved my mama's life. There's lots of stories that way.
Exactly. Yeah. A family member has a heart attack. Right. They rush them to the hospital. Dr. XYZ rushes in, saves the day.
Right.
You want to, you want to give Dr. XYZ a hug. They can do no wrong. Sure. They saved your family member's life.
Sure. But it's such a reasonable ask to just say, we just want to know how much it's going to cost. And so I'm still trying to wrap my brain around, and the implementation of it will really determine like what it ultimately ends up meaning. But I mean, if everyone knows the price, big insurance carriers, that's a huge hit. That's not a good day for them, because you're going to have to explain to them. There's lots of explaining that's going to have to happen because if you look at it from, say you're just a local doctor, say you're my doctor or my physician, and I go, okay, help me understand something. For this insurance carrier, it's going to cost maybe my company, and this is what they're thinking. Well, they don't care. I'm going to hit my deductible either way. If it's $20,000 or if it's $40,000 for that surgery, or for my surgery, more like 40 or 80, right? So if it's either one of those numbers, I hit my deductible either way. I don't care. That's true. However, the people that design that plan really care. And so they're going to go, help me explain, because I'm looking at your outcomes. And I'm going, okay, if you have better outcomes, then maybe I'll pay a little bit more. But your outcomes maybe are in the middle, and you want to get paid way up here, there's a disparity. And so there's lots of people that are pissed. The insurance carriers are pissed. The hospitals are pissed. That physician's going to be pissed. There's lots of people that aren't going to be happy with transparency, but ultimately, not immediately, I do believe ultimately there is someone that's going to be really happy about it, and that's the consumer, which is ultimately the point anyway.
I think I know what you're saying. I think what you're saying is I need to take $2,000, put it in a Robinhood account.
Right.
The minute this executive order goes through,
right,
I need to get 2-to-1. I need to click that I'm an expert, get 2-to-1 leverage.
Right.
And
National Health Insurance Carrier puts.
Sell calls on the National Health Insurance Carriers. Get that money in, 2-to-1, leverage it up, and then ultimately buy puts.
So, right, exactly.
Like our Reddit friend.
That's exactly right. You sell the calls, get the premium, and buy the puts.
Yeah, 2-to-1. Just keep selling those. Well,
that's exactly right.
Yeah.
That's right. Before earnings, 1 day out.
1 day out, expiration.